Hello, everyone. Today, we're diving into a clinical review of the Bacille-Comet-Guillain vaccine, or BCG, as we all know it. This whole explainer is based on the excellent guidance put together by Dr. Mohammed El-Naji Mohammed, and we're going to cover all the essential stuff every clinician really needs to know to use it safely and effectively.
So here's our game plan. We'll start with the basics of what the vaccine is. Then we'll get into who should get it. After that, we'll talk about the critical skin test you need to do first, how to actually administer the vaccine, and finally, we'll cover the really important part, who you should never give it to.
All right, let's jump right into part one, the fundamentals. Before we can use it properly, we've got to understand what we're actually working with. So what is the BCG vaccine? First and foremost, it's a live attenuated vaccine, and that's a point we really have to remember. It comes from a strain of Mycobacterium bovis, which is basically a cousin to the bug that causes TB in humans. Now, attenuated just means it's been weakened in the lab, so it can't make a healthy person sick, but it's still alive enough to wake up the immune system and get it ready to fight.
Okay, so what does it actually protect against? It's absolutely crucial to manage expectations here. Its main job is to protect against tuberculosis, but, and this is a big but, its protection is limited. Where it really shines is in preventing the most severe, widespread forms of TB in young children, like TB meningitis. It's much less effective at stopping adults from getting lung TB in the first place. And as a kind of cool secondary benefit, it offers a little bit of cross-protection against leprosy too.
Let's move on to part two. This is the practical question, right? Who are the specific patients that we should be vaccinating based on the current UK guidelines?
To figure out who gets the vaccine, you first need to burn this number into your brain, 40 per 100,000. This single number is the magic threshold for TB incidence that drives a huge chunk of UK public health policy. When TB rates in a particular area or in a person's home country hit this number or go above it, it triggers the recommendations for vaccination.
So using that number, the guidance for kids becomes pretty clear. The Green Book tells us to vaccinate all infants under 1 year old if they live in a high-risk area in the UK, or if they have a parent or grandparent who came from a high-risk country. For older kids with that same family background, they still qualify, but if they're 6 or older, you got to do a tuberculin skin test first. The policy also makes sure to cover kids under 16 who are new to the country from these high-incidence places, as long as they haven't been vaccinated and their skin test is negative.
Now, it's not just about kids and where their families are from. There are two other big groups we need to think about. First, anyone who has been in close contact with a case of respiratory TB. For them, it's kind of like post-exposure protection. And second, we have people in certain high-risk jobs. We're talking about healthcare workers, prison staff, people working in nursing homes, and those who work with the homeless. Basically any profession where exposure is much more likely.
Which brings us really nicely to part three. Because before we can give this vaccine to most people, there's a mandatory step we have to take, the tuberculin skin test.
So what is that prerequisite? And I have to say, this is a step you just cannot afford to miss in almost every scenario.
Yep, it's the tuberculin skin test, like the Mantoux test. And the logic here is really simple and sound. The test is just checking to see if the person's immune system has already been exposed to TB. If the test is positive, it means they have been. Giving them the vaccine at that point is not only pointless, but it could cause a really nasty local reaction. Now, there is one important exception. Kids under 6 who have no known contact with a TB case. We can skip the test for them because the chance they've been exposed is just so incredibly low.
Okay, on to part 4. So you've checked everything, the patient is eligible, the skin test is negative. How do you actually give the shot? The technique is very, very specific.
You have to follow this protocol to the letter. First, double-check that the tuberculin test was negative, unless they're in that under 6 exception group. Second, and this is critical, the route has to be intradermal. This is not a subcutaneous or an IM injection. That really shallow injection is what creates the little bleb, an inflammatory response that eventually becomes that classic BCG scar. And third, the standard spot to give it is the outer side of the left upper arm, right around where the deltoid muscle inserts.
Now, here's a practical tip that comes up all the time. What about giving it with other vaccines? Since BCG is a live vaccine, you can give it on the same day as other live vaccines, like the MMR. Just make sure you use a different arm or spot. But if you don't give them on the same day, you have to wait at least 4 weeks in between. And that's to make sure the immune response from the first vaccine doesn't mess with the effectiveness of the second one.
And that brings us to our final and arguably most important section, Part 5, Contraindications and Limitations. Knowing when to give a vaccine is important, but knowing when not to is a matter of patient safety.
So here they are, the absolute no-goes. A few of these are pretty obvious if you think about it. If someone's had a BCG shot before, has a history of TB, or has a positive skin test, all of those mean their body has already been sensitized. Giving another dose is just asking for trouble. Then you have pregnancy, which is a standard contraindication for most live vaccines because of the theoretical risk to the baby. And finally, and this one is a huge one, HIV infection or any other kind of serious immune system problem. Their body might not be able to handle even a weakened bacterium, and it could lead to a very dangerous, widespread infection.
Lastly, there's a key limitation to be aware of, and this one's about age. As a rule, we don't give the BCG vaccine to people over the age of 35. Now, this isn't because it's dangerous for them. It's simply because we don't have good evidence to show that it actually works to protect that age group.
So, let's wrap this up. We've seen that the BCG vaccine is an incredibly important tool, especially for protecting kids from the worst forms of TB. But we also have to be honest about its limitations. It doesn't work perfectly for everyone everywhere. And that reality really forces us to ask a much bigger question for global health. If this is what we have now, what does the future of preventing TB look like? Where do we go from here?